today's VMR. Welcome, it's nice that you're here. My name is Leah. I'm a medical student from Austria, and I get to co-discuss today with Rabih. And we're going to have, as usual, a case that is hopefully presented by one of you guys. So if anybody has a case, please let us unmute or let us know in the chat. Yeah, it would be great to learn from you and the case that you bring and share with us. So don't be shy, just let us know. It doesn't have to be any particular style or case, or however you're going to present it, it will be good. And first time is always a good time to do it.
Leah, I couldn't agree more. Thank you. You know, a case is a gift in so many ways. It's a gift to keep this community alive, which essentially depends on it. It's a great thing to add to your CV. If you're watching on YouTube or here, you should check out the emails that you get. There's specific instructions for how to make sure that you're getting credit where credit is due. And this is not quite a peer review publication, but certainly a peer review process where all these people are scrutinizing and analyzing the case you're presenting. So I know programs are increasingly interested in seeing non-traditional quote unquote scholarship. So yeah, amazing. All right, Zach, come. Welcome back. It's so great to see you, and we'd love to hear your case. Do you want to reintroduce yourself to the crowd?
Yeah. Hey, everybody. Can you all hear me okay?
Yeah, I hear you great, actually. Really nice.
Okay, awesome. Yeah, I'm Zach Owens, a PGY2 resident at Emory with
Yes.
So glad to be back with y'all.
I remember your emphatic introduction to VMR about a month or so ago, if I'm not wrong. It's really nice to have you back.
Yeah, glad to be here. Yeah, let me know whenever you guys are ready, and I can get going.
Yeah, absolutely. I just want to extend a warm welcome to somebody I met in person after a long time. Hamingyu, how are you?
Hi. Yeah, it's wonderful. I realize I just need to keep really return to this community. Yeah. So yeah.
We're delighted to have you back. Thank you. And I were colleagues at UCSF, and unfortunately you had to go for very good reasons, but we're thrilled that you're able to be close by through VMR. Nice to have you around. And of course, Nalayan has his video on. Oh my God, Nalayan, you have to say hi. What's the news?
Hi, Rabih. Am I audible?
Yeah, you sound great.
So I just finished internship, which is
you just finished, huh? How does it feel?
Internship is unlike internship in US. So internship in US is I think PGY1.
Yeah.
In here it is here after med school, and I'm so delighted. I'm currently preparing for residency.
Incredible. And when does that second phase start?
August.
August. Okay. What do you have between now and August? What occupies your time?
Harrison. Ethan has motivated me so much. All day long, I just solve clinical cases, relaxation. I just ended my internship a couple of days back, so it's just relaxation and chilling.
Fantastic. Well, you know, it's always a treat to have you here, and especially when you're able to turn your video on. Thank you for joining us. Leah, I hogged the mic because I know I'm not going to have anything to contribute to the case, so I would just sit back and let this audience bask in your wisdom. But Zach, take it away, please.
Yeah, for sure. So the chief complaint is syncope, and so I'll give you a little bit of background for the case. It's a 59-year-old female who was brought in from the elevator, or the elevator in the parking lot of the hospital that we work at, after she had a kind of abrupt syncopal event in the elevator. She hadn't really been feeling abnormal at all that day, but when she got on the elevator, she felt a little bit dizzy and lightheaded and kind of fell to the ground, and was brought to the ER by some people in the elevator with her. She didn't have any prodromal symptoms, chest pain, palpitations, and she's never had a syncopal event like this before.
Okay, thank you, Zach, for that introduction or presentation of the case. So syncope, I think immediately when I heard the term syncope, I always, in my head, there's these three branching points. Is it cardiac syncope? Is it vasovagal syncope? Or is it sort of your orthostatic hypovolemic bucket of syncope? And the three, I think this is something where history can help you a lot with differentiating between these three, because there are signs that are typical. For example, if you have your vasovagal syncope, you would often associate that with prodromes, yeah, or for example, somebody doing vasovagal procedures, or like sitting on the toilet, and these, where I'm missing now the terms to describe it, but something that can trigger that. And with prodromes like dizziness, which is quite unspecific, I'll say that, but feeling like they want to throw up, that would be things I associate with that. And then also with orthostatic, you can say, okay, did the patient stand up, and changing position was something that made him feel really dizzy? Or is he taking any medications, or are there indications for hypotension or hypovolemia? And then the cardiac, which is the one that I kind of had the first thought for this case, because it was like a sudden presentation of syncope. And cardiac for me is something is wrong with your heart. It could be either arrhythmia. I like to think, is it too fast or too slow? Or is there some kind of obstructive cause, or heart failure in that sense? PE could also do that. But what is specific, or I guess typical for cardiac, is that it's like sudden, and that it can come without any prodrome, and which also makes it very morbid. So I would want to know past medical history, medication, ECG, also if there's any other signs for cardiac causes. And that's where I would start for this patient.
Yeah, I have absolutely nothing to add to your fantastic stream of thoughts as you started from the word syncope to having a broad DDX, but then prioritizing cardiac. And as is true with all my conversations with you, sometimes the only thing I can add is to actually rewind the clock a little bit from the word syncope before that, not forward. And I think that in Zach, I think we have somebody who you can lean on to really mean syncope when he says it. Though in real life, often you have to ask yourself, well, what do I actually know for sure? And syncope is defined strictly as a transient loss of consciousness as a result of transient hypotension. And unfortunately, in many instances of where syncope happens, the transient nature of the phenomenon means that we don't have access to that reliable data. So often if you're asking yourself, okay, listen, let me be real, what do I actually know? What you actually really know often in the word syncope is something happened for a short period of time to this human being. That's all you really know. And so the transience of the event is often the most characteristic feature. What you often know to almost a degree of certainty, but not quite, is that the patient had a transient loss of postural tone, which in normal, plain, non-fancy English means that somebody fell. That's all you really know. And the question is, did they fall because of a loss of consciousness, or did they have a mechanical fall? So often when you're in the world of syncope, in some instances, you end up diagnosing peripheral neuropathy and fall. And sometimes you end up diagnosing vasovagal syncope. Sometimes you end up diagnosing seizure. And what brings them together is the fact all we know about this patient is something briefly happened to her. And since the word syncope is being used, presumably she's better. So the only thing I think we know is it's transient. The inference we can make is she has a transient loss of postural tone. And the key question is did she actually lose consciousness or not? And the problem is it's going to only be educated guesses because none of us were there. We're going to be relying on her testimony, witness accounts, her risk factors for the disease. But I think the only thing we know is something happened briefly to her. And we'll try to see how much confidence we can build by looking back at the data to see, well, what actually happened? Are we solving a transient loss of consciousness, or are we solving a transient fall with preservation of consciousness? And that'll be interesting to reflect on. But yeah, I think that if you are confident that this is syncope, which we can only get after we get more information, I think that as a DDX that you outlined is superb. By the way, I just wanted to outline a record for VMR. I think I was just looking at the participation. I think Aisha is setting like literally a VMR record. I think this is like her 10th VMR in a row. So welcome, Aisha. Thank you for keeping VMR alive. We appreciate you. Alrighty, Zach, tell us more, please.
Yeah, and so we'll add a little bit to her HPI. So the kind of syncope event was witnessed, and at least from bystander report, she did fall and lose consciousness. She didn't hit her head or anything like that, but she did regain consciousness after about 1 to 2 minutes and returned to her baseline pretty quickly afterwards, and was kind of funneled over to the ER relatively urgently. Moving on to her past medical history. So she has asthma, which is treated with an ICS and LABA. She has acid reflux, which is treated with, I think, pantoprazole she was on. And she also has a history of chronic sinusitis, and pretty recently had undergone a nasal polypectomy and removal of a thorn-walled cyst. And the culture from that had come back growing Pseudomonas. And she had, like, 1 to 2 days prior to admission, completed a 4-week course of ciprofloxacin. And otherwise, in terms of family history, there's kind of no pertinent family history in terms to this case. Social history, no smoking, no alcohol use, no recreational drug use. In terms of like health-related behaviors, there was nothing pertinent to this case, and she had no medication allergies.
Okay, should I start again?
Yeah, you can go ahead.
Well, thank you again. I think this is interesting. So with the past medical history, I'm not sure I can make anything special or link that to the current presentation. So no specific thoughts coming here. I guess the first thing that stood out to me was the Pseudomonas infection that this patient had. I was like, where did she get that? That would have been the question I have, because usually I associate that as being a health or a hospital acquired bug, and I would want to know: were there any contact with the hospital? Are there any other risk factors, or also it's a bacteria that likes to be like in wet spaces? So I guess that would be interesting to know. Although the infection in itself, I can't link directly either to the current presentation. There was a really cool comment in the chat that I thought was is worth highlighting, which is that the medication that she got, which is ciprofloxacin, it's part of the fluoroquinolone, I don't know how to pronounce it, group, which is an antibiotic that is part of the DNA disrupting antibiotics, and one of the side effects of that would be QT prolongation. So definitely, or that's the only medication that I would associate that could mess up a bit the cardiac system in terms of arrhythmia. Other than that, there's nothing else that I could link to the current presentation. Rabih, do you have anything else?
No, I think that's a superb connection that you outlined. It's a great opportunity to review the side effects of the quinolones, inspired by Yusuf to do a little bit of management reasoning. So the quinolones are a broad class of antibiotics. Commonly in the United States, we use ciprofloxacin, moxifloxacin, and levofloxacin, though there are other ones outside the US like norfloxacin and oxyfloxacin. And the biggest side effects all start with C, or have C in them as a prominent letter. So confusion is a big one amongst older adults. QTC prolongation, Coumadin toxicity, and C. diff are the big ones. And so here, Leah, I think that point deserves re-emphasis. It really is a thing to think about, though. The incidence of QTC prolongation with the quinolones is high. The incidence of any clinical significance as a result of that is very, very low. So here, the association is notable, it's worth pursuing, but the base rate of it would be exceedingly rare. So even if the EKG shows QTC prolongation, the number of people with asymptomatic QTC prolongation from quinolones is so high that you have to make sure that that's not an innocent bystander secondary to another disease process. And I love what you just did there. You're saying, hey, you know what? There's not much robust connection in the medical history. There's this fun fact that's worth keeping in your back pocket, but it's hard to lead with it given the incidental nature of it quite frequently. My dear friend Tim Yang, who I also just met a few days ago in Austin, is a rising chief resident over at Kaiser Oakland. Welcome, Tim. It's nice to have you here. And yes, thank you for emphasizing another C, which is dissection, or the other way of adding it to your repertoire is connective tissue. I forgot to mention it. The other C is connective tissue for the quinolones. So you can have Achilles tendinopathy, retinal dissection, and of course, aortic dissection. Yeah, there you go. Carolyn's on the Achilles too. Make it easier for yourselves, maybe, and add connective tissue as the big C. That's what my mind does. But I love the theme of the C's going. Yeah, I think there's one interesting thing to reflect on, and I think this case may bring about this point, which is I think it's hard not to now be confident in the HPI saying this is syncope. You know, we were much more confident with that second sentence that Zach gave us, that somebody saw her, she fell, she lost consciousness, and she woke right back up. So it's very unusual for hypoglycemia to do it. It's very unusual for seizures for you to just like wake up and be normal. So that's very suggestive of syncope. And you already made a compelling argument as to why you should prioritize cardiac, because it's the most morbid one and it tends to be the most abrupt one. And I would just make the point that as you try to pursue cardiac hypotheses, they fall into one of two categories. And those two categories are the patient had a transient arrhythmia or the patient has obstructive cardiac disease. So let's just take a moment to try to prepare ourselves for what Zach may give us. So when we think of cardiac syncope, what diagnoses have you seen that are cardiac in nature that present with syncope? I'll give you an example of something that doesn't. Heart failure does not present with syncope. It presents with dyspnea, orthopnea, PND. Acute coronary syndrome presents with chest pain, does not present with syncope. So when we say cardiac diseases presenting a syncope, what checklist crosses your mind?
Yeah, that's a great question. I think one, just because I saw many cases from that already, would be like a PE, so the vasculature, that could cause syncope in that sense. Yeah. And then also arrhythmias in general, too fast, too slow, or aortic stenosis is one of the famous ones that we know, especially, yeah, that's the typical one you always have to think of. Or I would also say just in general, low output cardiac causes. So whether it be a stenosis, a myxoma, a cardiomyopathy, something like that.
Yeah, you hit the nail on the head. Everything that you said is true. And now the question for us is to try to see, is there an underlying simplicity there? Is there something elegant and simple that allows us to understand why it's only these things that present with syncope? And the answer to that has to comes to fruition when you realize what the key variable in syncope is. The key variable is transient. How can somebody literally almost die, meaning they have a non-perfusing pressure? They're in that moment when they're syncopized, by the way, if that process continues, they're dead. That you have to code them. So how can somebody have such a bad cardiac issue that takes them to the verge of death and they come back by themselves? How does that happen? And that's the filter. And the filter is you either have a transient arrhythmia that aborts itself, it stops, or you have a critical obstruction. The obstruction is so bad and so advanced that if you challenge that obstruction, the cardiac output plummets. But if you fall flat and relieve the obstruction, the patient wakes up again. So really advanced aortic stenosis, if the patient exerts themselves, becomes hypovolemic, that obstruction becomes more manifest. Same with HOCM. So look at the list in the chat. Everything falls into either an arrhythmia or an obstructive physiology that worsens with a trigger. Hypertrophic obstructive cardiomyopathy, atrial myxoma, valvular abnormalities, aortic stenosis, HOCM. All of those things are either an arrhythmia, a sudden discharge of electroactivity, Or the patient is standing on the edge of a cliff, and it's because they have an intracardiac obstruction. And then there's a trigger that worsens that obstruction. And as soon as the patient falls to the ground, the obstruction now is relieved, and they wake up again. So as we think of those two categories, I would like to make one advanced point to help us prepare for this, the cardiac hypothesis. Obstructive disease usually leaves a chronic signature on the patient that is evident even after they return from the precipice of death. You'll hear the aortic stenosis murmur. You'll hear the myxoma plop. You will hear the flow murmur of Hocum. You will hear the obstruction. In contrast, silent, deadly syncope is usually arrhythmia. So my mind is really waiting for Zach to tell us what his stethoscope showed. Because if his stethoscope is silent, it's gonna be an arrhythmia if it's cardiac. Now, there are some exceptions. The stethoscope is not good enough to pick up some obstructive disease, but a normal exam highly prompts us to scrutinize the EKG to that level of detail. But if the exam is abnormal, we're probably dealing with some sort of obstruction. So I just wanted to pay out that picture that cardiac is either an obstruction or an arrhythmia, and the initial exam helps us make a very educated guess if it's cardiac. Any questions about that, Leah?
No, not at the moment.
Okay, alrighty. Okay, Zach, tell us more, please.
All right, let's keep going. So her temperature was 97.4 Fahrenheit. Blood pressure was 101/60. Respiratory rate was 18. Heart rate was 136. And SpO2 was 98% on room air. And then going through physical exam, in general, she was not chronically ill appearing and was not in any acute distress when we evaluated her. From a neurologic standpoint, she was alert and oriented and had no focal neurologic deficits. On her HEE&T exam, she did have conjunctival pallor bilaterally with no scleral icterus, and did have a little bit of petechiae under her tongue, no cervical lymphadenopathy. Cardiac exam, she was tachycardic, but it was regular. And she did have a 2/6 systolic flow murmur appreciated at the left lower external border. Otherwise, like no edema, normal jugular venous pulse, and she was warm and well perfused. And then pulmonary exam was normal, abdominal exam was normal. And on her kind of skin and extremity exam, she did have kind of a very faint petechial rash in her legs bilaterally.
Okay. Wow. So to pick up now, Rabih, what you outlined before, did we see something or not? I think yes, we have signs on the clinical exam now, which is interesting to put it together. And I'm not sure I know yet how to put everything together. First thing that stood out to me is the low blood pressure. So hypotension, then the I don't know how, maybe that would be a question for you, whether for me, the pulse pressure seems normal here. So I'm not sure how whether you can say, is the cardiac output now normal? We just have, or okay, we just have a low blood pressure. So maybe also with the peripheral resistance a problem, or would you say, no, the pulse pressure doesn't have anything to do with whether cardiac output is limited or not. But tachycardia is just, I think, the body's adequate response to hypotension. Hypoxia is nice for me to hear because I was also thinking about PE. I mean, PE doesn't always have to show that, or hypoxemia, but that's also a thought I had. Then systolic murmur, I think that's probably the main next to the petechia, the main finding also here. And what cardiac causes can cause a systolic murmur? I think aortic stenosis is the most common one, mitral insufficiency, of course, aortic regurg as well, but then we would expect an elevated pulse pressure as well, and maybe other signs. And I think aortic stenosis, you would maybe expect it more higher up, but because it's the most common one, I think I would still put that on the first of my differential. And now the petechial rash on the legs and subungual, which is interesting. I'm not really sure yet I know what to do, but I thought, okay, maybe an endocarditis can also cause these lesions on the nails. And we had this Pseudomonas in the past. Maybe there was still something that is very resistant in there, or it's another cause. So I would definitely also put that on my differential. But this is just the first thing. Maybe I would have to think more to find other causes in this context for the rash. But I would give the mic over to you, Rabih.
Yeah, Leah, I think this case got really, really complicated all of a sudden, and I think that your analysis of the cardiac dimensions are superb. And I'll just provide a 10,000-foot view that I think that I wouldn't be in real life solving this problem with syncope. It's no longer syncope, and let me explain why. Syncope really means that something really transient happened to this person. They were fine, boom, something bad happened, and then now they're fine again. I don't believe that they were fine to begin with. And if you have reason to believe that your patient wasn't fine to begin with, then you probably shouldn't call it a syncope. So what's the evidence that they're not fine to begin with? Conjunctival pallor and a petechial rash don't begin the moment the syncope began. So all of a sudden, here's what I'm actually worried about. I'm worried about the patient has had a progressive disorder like this of unclear time course that has happened. Worsening, 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 worsening. Critical phase in the elevator syncopizes, and then now is a little bit better, but is only going to get worse and worse. So strictly speaking, syncope is a monophasic disease with a rapid deflection from baseline with rapid return to baseline. This patient does not have a stable baseline. And what inferences can we make from that? Most patients, when they return from their syncope, have a completely normal vital sign. Their arrhythmia is gone, and their obstruction has been fixed or temporarily improved. The fact that this patient has abnormal vital signs means she does not have a stable baseline required to diagnose syncope. So this patient has tachycardia, hypotension, conjunctival pallor, and a petechial rash, and happened to have transiently lost consciousness. And so I'd be very careful, no longer calling this syncope, calling this tachycardia, hypotension, anemia, and likely thrombocytopenia. The anemia inferred from the pallor and the thrombocytopenia inferred from the petechial rash. The anemia is a much more powerful inference. It's very predictive. The petechial rash correlating with thrombocytopenia is less robust because there can be other causes of petechial rashes like vasculitis, for example. So that's how I'm formulated. I'm curious how that lands with you and where you're taking that.
I think, yeah, an important thing that I didn't mention before, but it makes really sense, is to highlight also the anemia part of it with the pallor, and then thrombocytopenia that might have resulted from it, or one has caused the other. But I really love the point how you contrasted that the vitals, you would expect them to be normal if it's just syncope, and I never thought of it that way. So I'm curious now how the labs will confirm that or not. And then I guess, yeah, it makes us more concerned and maybe want to act faster with this patient now that we expect this bicytopenia.
I completely agree. And I think the things that would confirm that we're on the right path is this murmur turns out to be a flow murmur from anemia, and the tachycardia turns out to be sinus from anemia. We still have to be open to the possibility that there's a cardiac footprint to this disease, this murmur being something else and the heart rate not being sinus. But I think the momentum is certainly now towards a hematological issue that happened to have stressed the heart. All right, Zach, tell us more.
Right, yeah, we can move on to the labs. So for the CBC, her white blood cell count was 10.4 with a neutrophilic predominant differential. Hemoglobin was 4.7. with an MCV of 84. And then her platelets were undetectably low, less than 1. And let's see, for metabolic panel, sodium was 135, potassium was 3.5, chloride was 99, and bicarb was 26. BUN was 36, and creatinine was 1.1. And let's see, her liver enzymes, AST, ALT, alk phos, and bilirubin were normal, as was her albumin. And then I'll go ahead and give you guys the EKG as well. So the EKG was sinus tachycardia with no STT changes concerning for ischemia, no evidence of like chamber enlargement, and had normal intervals, including the QTC interval. And she also had a chest X-ray that was normal.
Wow, okay. That is quite a devastatingly low platelet and hemoglobin count, and also confirms the predictions you made before. So now I think I will just list a few things and then maybe say what might be more likely, but definitely no missed causes of bicytopenia would be HIT or a MAHA. So something like TTP, HUS, DIC also, and sepsis is also something that can cause these two. But I think what strikes me more is that the platelet count is really undetectable, and things that cause bicytopenia, there are many, but maybe less that cause such a low platelet count. And I also recently learned that even when differentiating the MAHAs, like HUS and TTP, the TTP is the one that will cause the lower platelet counts. So even with those two, I would prioritize the TTP and also check for, in this case, the plasmic score. Was there any heparin exposure that could have been possible, or is there any autoimmune cause that might have caused the platelets to be low? Like we learned recently in a case that ITP is something to think about when we have an undetectable platelet count. And maybe that was also causing bleeding, which causes the low hemoglobin. So yeah, and I think ITP is a diagnosis of exclusion, so it's hard to make the diagnosis here. But definitely do a blood smear, as also people mentioned in the chat, to find out if there are any schistocytes or other signs.
No, you're spot on, my friend, spot on. Whenever you're in this situation with anemia and thrombocytopenia, you have to hold your breath until you know 3 things. Schistocytes, yes or no. Heparin, yes or no. And blasts, yes or no. Because unless you look at the peripheral smear, that whole that count of 10.4, even though the manual, the automatic review says they're neutrophils, you have to make sure they're not blasts. So literally hold your breath. Schistocytes, heparin, and then blasts. And after you've thought of blasts, you can finally breathe. And Leah, you said all of that and more. So I have really nothing else to add. All right, Zach, tell us more.
All right, yeah, I will kind of follow up with some extra history. This person was admitted overnight, and we went to go talk with the patient in the morning. It sounds like she had felt a little bit of fatigue for like 1 to 2 weeks before all of this happened. It had been getting worse. So it doesn't seem like it was as an acute presentation as kind of we initially thought. But okay, I can go through some more of her lab data for you guys. Let's see, her retic count was low, so it was hypoproliferative. She had iron studies that showed normal ferritin, normal iron, normal TIBC. She had an LDH and haptoglobin that were normal, B12 and folate that were normal, and also had a peripheral smear that showed no schistocytes and no blasts, and just noted that she was anemic and thrombocytopenic. And let's see, she also had HIV, hepatitis C, and Hep B check that were all normal as well. And kind of like on a management update, you know, the patient was given a liter of fluid when she got to the ER. Once they discovered the anemia, she was transfused. I think two to 3 units of packed red cells and kind of a bag of platelets as well. The ER was concerned that there may be kind of a GI bleed, so they get a CTA GI bleed protocol that didn't show any evidence of an acute GI bleed or any like intra-abdominal organomegaly.
Wait, oh my gosh, this is so intriguing. Leah, I'll just jump in to say I think it's probably a good time to gauge, in addition to your analysis, what your summary is. So do you want to give a crack? I saw a couple people who just joined, and I also think this case is getting a little complicated. So do you want to summarize what your problem representation is, and then tell us what you're thinking with the new data?
Yes, so this is a 59-year-old female presenting with syncope, and not really remarkable past medical history, recent Pseudomonas infection and treatment, and now evidence of anemia, severe anemia, and thrombocytopenia on labs. So I think it's really interesting because it's very helpful. I think the labs that we got are really helpful. But so what is the reticulocyte count is low. So somehow we have low production, which kind of thinks is what's the problem with the bone marrow. So something is wrong there, because we would expect it to want to produce more with such levels of anemia. But then the ferritin was within normal limits, which is interesting. If there is an inflammatory process going on, maybe I would expect it to be higher. But okay, let's just leave that aside. And then the LDH and the haptoglobin is pretty much makes hemolysis very, very unlikely with that being normal. And also the MAHAs then very unlikely. And the smear, as you said, we should hold our breath until we see schistocytes or blasts. Okay, they were not seen, which makes sense with the labs that we already had above, because I would expect inflammation with malignancy and also hemolysis with schistocytes. And now, okay, I'm like, wait, maybe then what could be the cause of this? Is there so somehow the bone marrow is the only signal we get that there's something is wrong there. So I would want to know, is there some sort of aplastic anemia that doesn't involve the white blood cells, and or one causing the other, but there is no signs of bleeding in the GI tract, which so I think it's a really important test that was also done. I'm thinking, okay, maybe it is something immune mediated, where it's kind of an almost diagnosis of exclusion sort of thing. But a bone marrow biopsy could help us find out what we see there. And maybe then there are particular diseases or syndromes I don't know about that really touch the red blood cells and the thrombocytes. Yeah, but that's where I'm at the moment.
I think your analysis is absolutely superb, and you make such a compelling argument for a bone marrow problem, even acknowledging the biggest counter argument against it, which is why are the hemoglobin and platelets so profoundly affected and yet the white count is completely normal? And I think that's a question that will really haunt us. But the overwhelming amount of data is suggesting, as you said, that there's a bone problem in the bone marrow. The reticulocytes are low, and you haven't found causes for bleeding or hemolysis, the two causes of destruction. And I would say that one very powerful variable to help you be even more confident there's a production issue is response to transfusion. So if the patient's hemoglobin and platelet counts bump according to what you might expect, that tells you there's a production problem. So a lot more certainty. And I think that when you're thinking about production problems or bone marrow issues, the question is it a stem cell issue or is it a problem with the environment? And so is it because the bone marrow stem cell is inherently dysfunctional, or there's a nutritional deficiency or a toxin or a hormone going on? And the truth is there's no evidence of any nutritional deficiencies. There's no obvious toxins except maybe some medications. So I think the invoking a stem cell issue like acute leukemia or aplastic anemia is important. And I think here the lack of blasts cannot sufficiently reassure you against the evidence of a blast in the bone marrow. So that would be the most morbid diagnosis. However, I think the most likely diagnosis at this juncture is probably a drug-induced aplastic type anemia, with the quinolones unfortunately being on the list of potential offenders to do that. And your only peripheral clue to aplastic anemia versus acute leukemia is that acute leukemia tends to be more hectic and more systemic and more burdensome on the patient. And this patient curiously barely noticed her hemoglobin of 4.7. The other clue to the presence of aplastic anemia is studying the reticulocyte count even more closely, because reticulocyte count in aplastic anemia tends to be ridiculously low, not just normal or on the lower side. It tends to be fairly low. So I might whip out the microscope and look at just how bad is the retic count in this case. But I think you're right. I think a bone marrow biopsy will be revealing, and scrutiny of her drug exposures, because drug-induced aplastic anemia is on the list, is probably a good idea. I didn't realize we were rambling so much and are fairly far over. So that please take us to the next step if you don't mind.
Oh yeah, for sure. Yeah, so after the patient got admitted, hematology was consulted. We didn't start her on dexamethasone, and she got a couple of doses of IVIG as well for just concern for like drug-induced ITP. She did ultimately get a bone marrow biopsy several days into the hospital stay, which showed hypercellular marrow with megakaryocytes present, which they mentioned was reassuring against a malignant process or neoplastic process, and was suggested that the bone marrow was starting to recover. We did have like FISH and flow cytometry and chromosomal analyses at the marrow sent, which all came back normal. And I think Rabih kind of mentioned on this, the final diagnosis in this case was Cipro-induced aplastic anemia and ITP.
Oh my gosh, like I have so many questions and thoughts and ideas. I'm just so grateful that you presented this case, because I think it really just goes to show us how humbling medicine can be.
Yeah.
But I would love to get your thoughts, Leah. I hope you listen to this one again, because your thinking was just spot on from the very beginning, and Zach took us on quite a windy road. But how does it feel? Any thoughts, reflections on this case?
Yeah, I think this is such a cool case, because again, we had so many twists in how the problem presentation just switched from starting off with syncope, but then it was really important for the patient, or for the best of the patient, to also change our frames and now solve a different problem. So I think that was very interesting. And I think the main thing I want to take away is blasts, because I think I underemphasized that in my reasoning, and definitely an important point to consider. But yeah, thank you for letting me learn also with you guys. I think we learned so much from this case, from the discussion, and the chat was just exploding too. So I think it was really cool.
Yeah, I'm so I'm stunned that you're finding your growth points and thinking about the blasts in a case where you were mesmeric in your conversation. And the truth is, I think the reason you probably didn't emphasize it as much as you like is in VMR, morbidity doesn't drive our thinking that much. We're all trying to think of what the answer is. In real life, I think morbidity influences our thinking more often. And I think that's probably why you knew it but didn't emphasize it as much, because here I think the case wasn't a strong one for leukemia. But Zach, I'm really curious what it was like to take care of this patient, and what lessons you took away from this case.
Yeah, she was a lot of learning in this case. I think the patient was, didn't really have many chronic illnesses, had never been in the hospital before, so she was very, very worried about the possibility of this being cancer. And so I think, I learned a lot just in terms of like how to, communicate those types of things with patients and, kind of comfort her and make sure she wasn't worrying too much about it and that she was, very aware of like what we thought the most likely problem was going on and that we were doing all of these next steps to make sure it wasn't the most worrisome thing. But yeah, it's also kind of like you guys had alluded to, like the problem representation changed so many times in this case that it really forces you to kind of take a step back and reevaluate and say, hey, how do we, change our thinking based on this new information that we have? And a lot of the problems that we had to solve for her are such core internal medicine problems that this was a case I saw very early in intern year. So it was a good learning case, and that I became a lot more comfortable with like anemia and thrombocytopenia and like hematologic abnormalities than I had been previously. So it's a very, very good learning case.
Oh my gosh, this is a case from your intern year, Zach. I don't even know what to say. I think literally like this is what I think we all strive for, to like latch on to cases rich with learning. And I really, really appreciate you taking the time to share that learning with the 30 of us here today, and hopefully many more later on. This lesson will really, really make an imprint on me. And I think you probably inspired a few people in the audience to like take a leap of faith and present their cases to share the learning because of your generosity here today. Really, really appreciate it.
Yeah, it was nerve-wracking the first time I presented. It was much less nerve-wracking this time. And I mean, the like CP Solver's VMR learning environment is so friendly, and there's no judgment and things like that. So thank you, kudos to you guys for just creating such like a safe space for learning and whatnot.
Heck yeah, but you're amplifying it to another level though, my friend. I really mean that. Really, really amplifying it to another level, and we really appreciate it. I wonder, going back to the case for a second, you got me thinking about the timing of things, because I think Leah brought up a really important point, just to ask you really a long-winded question, which is the white count was normal when you got the patient, and then you saw there was evidence of platelet recovery on the marrow. So if presumably the patient didn't syncopize, her platelets were probably recovered. I'm starting to whether she had like the reason that her case presented in such an unusual manner was her marrow was starting to recover as she sought care. And that's why her white count was normal and her platelet count was normalizing on the bone marrow.
Mm-hmm.
I'm curious, did that hypothesis come up? Because just to finish the question for everybody, it sounds like she stopped the quinolone a few days before. Is that right? Or
yeah.
Did that hypothesis come up for you all? What do you think about it?
It did, yeah. I mean, we just had no data from the time. Like we had labs and she started the fluoroquinolone that were stone cold normal, and then we had these labs that she showed up with. So we don't know if her white cells were also suppressed at one point.
Yeah.
And I will say her hemoglobin when she left the hospital was in the 8 region, and her platelets had normalized by the time she left.
Incredible, absolutely incredible. Whew. I don't know how we can make that into a C, y'all, but I think that's the task for another toxicity, the quinolones, is somehow make it into a C. But
yeah,
I'm sure I'll come up.
Yeah.
Oh, yeah, there you go. Nailed it. I love it, Zach. I absolutely love it. All righty, David. I see you very thoroughly organized teaching points here. I love it. Please take it away.
So, well, first of all, thank you, Zach, for bringing this case, because it's incredible, and the journey that you take us to. Well, it started with a patient presenting with syncope. Syncope DDX can be from 3 groups of causes. Reflex syncope can be vasovagal, situational, or from carotid sinus hypersensitivity. Orthostatic syncope can be from hypovolemia, from anemia, from autonomic dysfunction, drugs, vascular insufficiency, and well, also below dependent cardiopathy that can present also in orthostatic in a orthostatic manner. And also a cardiogenic syncope that can be from arrhythmia or from structural or obstructive causes, such as aortic stenosis, hypertrophic obstructive cardiomyopathy, etc. Also, aortic dissection is a thing that it's for me very more difficult to comprised in one group. In this case, the HPI and the history of anodes exposure made us think of the possibility of QT prolongation and syncope due to arrhythmia. But later, the exam, the petechial RAS made us think also of the possibility of vessel diseases and endocarditis and also it could be due to hemostasis diseases, thrombocytopenia in this case. I like the Rabih's reflection of being a monophasic transient disease, but in this case there are clues. There were clues. The payload, the systolic murmur, and the petechial RAS pointing to underlying processes and progressive process. And finally, the labs turn the case to another phase in which anemia and thrombocytopenia PDX mark the discussion. These two problems can have DDX that can be differentiated between high graphics with TMAs, TMAs, and other more rare causes being the possibilities. And in the folate deficiency, alcohol, hyperestrogenism, bone marrow process are the main possibilities. Well, just two pearls. Also Rabih mentioned the three reflex questions that we have to ask ourselves immediately when seeing anemia and thrombocytopenia. Are there schistocytes in the smear? Is there a heparin exposure, and are there blasts in the smear? And well, also that the response to a transfusion gives us a class a clue to think if there's a hyperproliferative or not process. And that's all. Thank you for the case.
Absolutely superb. That was amazing. So concise and organized. Thank you. This case was so complicated, and I think distilling it down into the 4 themes you have there, David, was absolutely awesome. Thank you so much. And thank you again, Zach. Thank you, Leah, for discussing. Just wanted to say that we're taking a little bit of a break from VMR, so we won't be around on Friday, Saturday, or Sunday, but we'll look forward to seeing you back on Monday. And hopefully Aisha can continue her record of 1 billion VMRs in a row. All right, y'all. Bye.